to design valid household survey indicators and questions about nutrition intervention coverage. We're going to wait for a couple minutes for people to join. We are a little bit early, so please hold on for about a minute until we wait for others to join. Welcome, everyone. We will get started in just another minute until we wait for more people to join the webinar. So good morning, good afternoon, good evening, everyone from wherever you're joining us. Thank you for joining today's webinar titled, Can We Measure That? A stepwise approach to design valid household survey indicators and questions about nutrition intervention coverage. My name is Cecilia Gonzalez, and I am the facilitator of the Data for Nutrition Community of Practice. So before we get started, everyone is muted during the presentations. This is format is on a webinar form. You can use the chat box at the bottom of your screen to chat with other participants, and you can contact Carmen Sultana if you have any technical issues. We will use the Q&A box for questions for your Q&A, and we will have a Q&A time later to also answer some of the questions that are picked by our moderator. A recording of this webinar will be available on the Data for Nutrition YouTube channel immediately after the webinar, and we will post the presentations on our Data for Nutrition LinkedIn group afterwards. We will post the slides. So I'll go to the next slide. If you're still having trouble with Zoom, please do contact Charmin Sultana. You can go to the chat, select all panelists, and then you can choose Charmin's name from the chat box. So very briefly, the Community of Practice Data for Nutrition provides members with opportunities to share knowledge, experience, and questions relevant to strengthening the nutrition data value chain at all levels for the purpose of achieving better nutritional outcomes in low and middle income countries. DFN, as we know it, has been active since 2019, and this year we have transitioned from our previous platform to a LinkedIn group so we can better connect, collaborate, and grow our community. Currently on LinkedIn, we are over 400 members, and we're still, if you're here, we encourage you to join us on our LinkedIn group, which the the link will be shared in the chat. So I'm going to pass it to our moderator today, is Shelley Walton, Senior Research Associate at the Johns Hopkins Bloomberg School of Public Health.
Thanks, Cecilia, and welcome everyone. Good morning or good afternoon. Thank you for joining today's webinar on an issue that really sits at the heart of nutrition programming, monitoring, and accountability. So why does this topic matter? As nutrition programs expand in low and middle income countries, we increasingly need valid and actionable data on who is being reached, who is being left behind. Yet many of our current indicators for nutrition intervention coverage are not valid, or they're difficult to interpret at scale. So this isn't just a measurement problem, as we'll lay it out. It's also a program and policy problem. If coverage indicators are inaccurate, we risk misallocating resources, misjudging program success, and failing to identify and close key equity gaps. So what will you learn today? Well, we have speakers that will share real-world examples using DataDENT's work in Ethiopia and Bangladesh on improving nutrition coverage measurement. We will particularly focus on maternal micronutrient supplementation, and you'll be introduced to a stepwise approach to improving intervention coverage indicators and survey questions. Our goal for the session today is not only to show why better indicators are needed, but also how researchers, implementers, and policymakers can really work together to design and refine coverage measures that are meaningful, valid, and scalable. So with that, let me introduce you to our wonderful speakers. First, we'll be hearing from Sunny Kim, who is a Senior Research Fellow with IFPRI. She'll be providing an overview of why we need to do better nutrition coverage. Then we'll hear a presentation from Alina Wood, who's a research associate at Hopkins, and she'll be going through step 1 of the process, which is focused on defining the intervention and context of implementation. We'll then have a presentation from our colleague Hannah Burhan, who's a Deputy Director of Research and Community Services at Addis Continental Institute of Public Health, and she'll be going through step 2, understanding context and how respondents conceptualize and recognize the intervention. And then finally, Emily Myers, who's a senior research analyst from IFPRI, will go through the last step. So step 3 on designing and refining questions. And then we'll open it up for Q&A and discussion. So with that, Sunny, over to you.
Great. Thanks, Shelley. And again, good morning, good afternoon, everyone. So I'll be starting us off by framing some of the concepts and issues related to coverage measurement and why we need better indicators and measures. Next slide. So what do we mean by intervention coverage indicator? And just to give a general definition here, it's the proportion of individuals in need of an intervention who actually receive it. So in the numerator, we're thinking about the number of individuals in need and receive that intervention over the denominator of individuals in need of intervention. So for many, in some interventions, there are some standard coverage indicators, like those that are used in surveys such as DHS and MICS, such as the percentage of children age 6 to 59 that receive vitamin A supplementation and so forth. But as we move and think about multi-sectoral nutrition, we know that that spans across multiple sectors and delivery platforms and a variety of different types of interventions. And for those, there may not be standard indicators and measures for tracking coverage. So interventions such as households with access to a variety of different types of fortified foods, aside from salt, or the percentage of households that are receiving nutrition-sensitive social protection programs, for instance. So we can think of a variety of different multi-sectoral nutrition interventions that have not yet been incorporated into widely into survey use for measurement of coverage. Next slide. So Shelley mentioned this in the intro, but why do we measure nutrition intervention coverage? We need high quality coverage data because we need to track the progress in evidence-based intervention delivery at the country and global levels. Most of the countries and at the global level, there are targets to be reached, and those can be tracked only by having the data and evidence to show any progress or lagging into to the efforts and actions of this. Also, at the subnational levels in the states, provinces, there may be targets and goals to be reached for tracking progress. We need to assess whether interventions are reaching those that are in need, considering equity, those are most vulnerable, whether or not there are gaps that need to be filled, and trends over time. Improving our programs and planning, we want to be able to prioritize where areas need to be strengthened, and evidence on and data about the coverage of nutrition interventions can provide that. Performance-based financing information requires that data, and also even modeling efforts to see how projected lives saved by certain interventions and health and nutrition benefits from those programs can only be done where data is available. Next slide. So countries actually have a variety of different data sources for monitoring intervention coverage and quality for different purposes. Each is really important for a variety of purposes and types of decision making. And across the top, we have at the household level, the population-based surveys, which are periodic, such as the DHS, the MIX, National Nutrition Surveys, SMART surveys. And then to the right, community level data, such as the community IHS, community health worker records. Those provide information about coverage of some interventions at the household level. And below, at the facility level, there may be administrative data, such as the HMIS, the DHIS2, and facility-based surveys that are also administered, like the SPA survey and the SARA survey. And the top left, upper left is circled because today, as we walk through the different state methods and approach for improving measures and indicators, we'll be focusing on the population-based household surveys. We know that the population-based surveys are typically used in low and middle income countries, and that for really tracking a lot of progress and used quite extensively for all the different purposes that I discussed prior and previously, and that household surveys are really the primary source of coverage data still. There are different advantages and disadvantages across all the different types of data sources, but it's really important that we continue to also improve the different sources of data and the data platforms simultaneously. That population-based surveys are characteristics of these surveys are that people often have to recall whether they received an intervention and report whether they need it. And if self-reported, there is a possibility of misclassification and bias, which we'll discuss. But these are still the main source, a primary source of coverage data. In terms of the administrative data, they're not necessarily representative of the population, and facility-based data, they would only be providing a snapshot of the population that are also accessing health services, and many beneficiaries may not be, population may not be coming to the health facility in which the administrative data is being tracked. Certainly, there's other examples of different data sources and uses of these different data, but I just wanted to highlight that there are different multiple data sources, but we'll be focusing again on the population-based household survey for this webinar. Next slide. Then why do we need better nutrition coverage measurement? We said that there's been limited comprehensive routine administrative coverage data across sectors for multi-sectoral nutrition interventions in LMIC settings, that high quality actionable coverage data for all key nutrition actions is limited or not available, such as for women of reproductive age, IFA supplementation, nutrition counseling during pregnancy, interventions for moderate and acute malnutrition, and large-scale food fortification. There may be some, but it may not be comprehensive across these different interventions. There's also evidence, growing evidence, but there's more to be done in providing data about the validity concerns on the existing measures due to recall and reporting bias and how to improve them. Next slide. So what makes a good population-based coverage indicator? Certainly needs to be representative of the population-based estimate. It needs to be valid in that the indicator is true and accurate measure of what's being measured, reliable, that it is consistent and dependable across countries and over time. There's the ability to detect the change within a reasonable period and as a result of the interventions. Ability to produce data that's easily interpreted to guide program change and decision making, and that it's consensus driven, that there are global and national actors related to the key indicators and components that provide guidance and a consensus across for the different measures and indicators. Next slide. So at the beginning, I presented a basic definition of a coverage indicator, but when we talk about coverage indicators, there are quite a different range. Coming from the left to the right, they may be detecting different components of service contacts and receipt. And from the left, these coverage indicators can include a basic contact with the service provided, to those coverage indicators that assess quality and content of the intervention. And in the center, you see that two of the indicators indicated here, which is that's boxed in red, the intervention coverage, which measures the receipt of the intervention, and the quality adjusted coverage indicator, which is the intervention receipt at the quality or recommended standards. And so really, we are most concerned about achieving good measures, solid measures, and indicators around intervention coverage and quality adjusted coverage. Next slide. So to create an indicator, we need to think about that the indicator needs to summarize the population covered by the intervention and the time period in which the indicators apply. So considering the denominator, we need to think about the number of the population who meet the criteria to receive the interventions. So you might ask, can your survey accurately capture whether respondents need the intervention? And for a lot of the preventive interventions, we may think of whole population groups, such as household members, or specific population groups, such as women, men, types of births, children by certain age groups that need the intervention. But as we get to more the treatment interventions, they may be a bit more narrowed denominator, and considering about who are those individuals that need the intervention. And in the numerator, the number of the population who meet the criteria to receive the intervention and receive the intervention, you we may need to think about, can survey respondents actually report accurately on whether they receive the interventions? And this really brings up the issue of recall and other aspects of reporting that may be challenging and brought with errors, such as when questions are asked about adherence or the count of an intervention received, or the certain specific timing, or specified detailed messages, such as counseling interventions that they had received, which may be challenging for respondents to report accurately. And third, thinking about the time period, what is the appropriate time period preceding the survey interview to which the measure applies? Next slide. So we mentioned what makes a good indicator above, and here I just wanted to raise that one of those important aspects is validity. And there's the subsequent presentations, the following presentations, will talk about addressing stepwise approaches and methods in some aspects of the validity. And I just want to raise that with validity, there's a variety of different types from the top to going to in clockwise. Can you push next slide or next animation? So from face validity, which we're asking about, do the measures ask what they appear to ask? Construct validity, do the measures relate to the theoretical construct or concepts? Criterion validity, here this is in comparing the measures to a gold standard or a better measure. And content validity, so do the measures cover the content of the constructs and concepts? So there are a variety of different types of validity, and again, the methods and the stepwise approaches we'll be discussing in the presentations presenting will be really addressing the face validity and content and some content validity of the of designing and developing measures and indicators. Next slide. And some threats to that validity for measurement coverage. I'll quickly just cover that, mention that there is the measurement error, which are errors that arise when respondents don't know how to answer that survey question, but answer it anyways, and providing it an information error, or bias, which arises from systematic errors in measuring interventions, such as questions that are it may be biased by social desirability and so forth. With the measurement error, this causes a imprecision around the point estimates. But with the information bias, one of the challenges there is that we may not know which direction in which that error is biasing the results in over or underestimating the point estimates. There's also, in the point of interpreting the coverage estimates, that's often that may take place is when coverage estimates that are administered at a unit level may be tried to be used to interpret for lower levels. For instance, national and state level, regional level data being interpreted for lower levels, such as district or subnational estimates, which make the estimate or the invalid for interpretation. And last slide, next slide, is that in the next presentations, they'll be illustrating specific methods on the application of this, but we need to consider careful indicator measure development. We need to really define the indicator, leverage the mixed methods to improve the face and content validity of the questions, and incorporate aids as needed. And this also requires this extensive pre-testing prior to any survey implementation so that the tools are really adapted to local norms and contexts, and still retain the key structure of the questions to standardize indicators across countries and over time. Okay, I've gone a little over time, but we have a next slide, a poll question, just to make sure that you're all following in with us still and to exercise your fingers a bit. So Sharma, can you pull up the poll question, which is which of these indicators are indicators of nutrition intervention coverage? And there should be a pop-up screen that appears. And this is a multiple choice, so you can select as many as that apply. But out of these 5 indicators, go ahead and I'll give you 5 seconds to quickly indicate which might be an intervention coverage indicator. Great. Sharma, do you want to show results or the next slide? Great. And then in the next, so here we see there's a lot of responses across all of the different indicators, but in the slide here, we bolded in red, we bolded the responses that are correct. At the top, exclusive breastfeeding is a practice after receiving interventions such as breastfeeding, counseling, and support. And then stunting is an outcome that assesses nutritional status of here young children. And so the responses are related to counseling, number 2, vitamin A supplementation, 3, 5, deworming. Those are evidence-based interventions, and the indicators, those indicators are displaying the coverage indicators. So something to think about as we continue to move forward. Go to the next presenter. I think it's Alina. Thank you.
Thanks, Alina Wood here. I'll now walk us through step 1 of the iterative indicator development process to defining the intervention context of the implementation. Next slide. Within this, the challenge is how do we define coverage of iron-containing supplements during pregnancy? So what's the intervention we're trying to measure? Next slide. So just to give a little background, globally, more than 23 countries are now exploring a transition from iron folic acid, or IFA, to multiple micronutrient supplements, or MMS, which I'll describe more in a bit. But these are in their ANC protocols, and several countries are actively scaling up MMS delivery. As countries move through this transition, we need to know who is being reached with IFA and who is being reached with MMS, and current national monitoring systems haven't yet caught up to reflect these changes. In household surveys, like the DHS, we commonly see indicators such as percent of women who took any iron-containing supplement, which is a valid indicator, and then percent of who took at least 90 tablets, which is not valid, and partially due to some recall issues. And this is part due to cognitive burden of a woman understanding the question, as well as being able to accurately recall the total number of tablets taken across her pregnancy, especially over a 2 to 3 year recall period. So measuring IFA has already proved to be complicated, and the introduction of MMS further complicates this measurement issue. Next slide. So defining the intervention is just the first step in this iterative process. We start by defining the use case for the coverage indicator. Are we trying to compare across countries, conduct a country-specific evaluation to focus on their policies and priorities, evaluate a specific program, or something else? This will determine how we'll define the intervention. And then we will clarify what is specified about the intervention, how it is delivered in the global or regional policy guidance and protocols. And throughout this, we conduct expert consultations and formative research. Then we move into designing and testing survey tools and revising the tools and the indicator accordingly. If you'll click next. Yeah, so in this first step, we'll be focusing on defining the intervention, but it's important to think about how this step feeds into and is also shaped by the steps that follow. Next slide. Okay, the point of this process is to develop an indicator that is both meaningful for decision making and feasible to measure. The way that we assess coverage also varies, and understanding which indicator we're working with is critical to know who is truly being reached and who isn't. This slide should look familiar based off of Sunny's earlier presentation, and just wanting to highlight here that those that are circled in yellow are being the most important. Next slide. So the key method here is landscaping, which includes reviewing policy and program documents. Next slide. So what does the guidance say? Well, the WHO recommends IFA for all pregnant women in settings with high anemia prevalence, and then MMS, particularly the UNIMAP formulation, where micronutrient deficiencies are common and evidence is available. IFA is usually 60 milligrams of iron and 400 micrograms of folic acid, whereas the UNIMAP MMS contains 30 milligrams of iron and 400 micrograms of folic acid, plus 13 other essential vitamins and minerals. It's important to remember we want to measure preventative supplementation, but women may receive iron for treatment and they may not know the difference or know exactly why they are taking the supplement. Next slide. So while we started looking at the WHO global guidance, we also need to look at the country or regional policy, as this reflects how the indicator is defined and implemented locally. If you'll click next for the animation. In Bangladesh, pregnant women can assess or access a wide range of iron-containing supplements. These include IFA tablets from government clinics, UNIMAP MMS from programs, and prenatal vitamins from NGO or private pharmacies, just to give us a few examples. And guidance around how they're delivered differs, and private and NGO clinics may not follow the same formulation or dosage as the public system. So the delivery channel matters, but the Bangladesh policy, which you're seeing here in red, doesn't define the intervention by delivery mechanism, though other countries might. But it does say that their regional guidance is 60 milligrams of iron and 400 micrograms of folic acid daily throughout pregnancy, and then onwards until 90 days after delivery. Next slide. So this is just a comparison of two MMS products. The one on the left here is the UNIMAP MMS, and that contains 30 milligrams of iron. And then the one on the right, which is a common private product, has 27 milligrams of iron and 800 micrograms of folate. So their nutrient profiles differ, but to a woman, both may be considered prenatal vitamins. So which ones count as MMS? Next slide. Great. So according to the current guidance, if you can go back. Yes. According to the current guidance, Bangladesh recommends the 60 milligrams of iron, 400 micrograms of folic acid daily throughout pregnancy and 90 days postpartum. Importantly, they don't yet have a formal national guidance for MMS. So this is our guidance for IFA. So if you consider if a woman took UNIMAP MMS for 180 days and a woman who took the nature-made prenatal for 180 days, which woman would be considered covered? Let's assume that both women were consistent taking the supplement, but neither of these products meet the current Bangladesh standard for IFA. And again, there's no formal MMS standard yet. This example just illustrates the complexity of defining what coverage really means. The answer isn't meant to be straightforward, and that's kind of the point. We need to carefully define the intervention and make sure that our indicators align with what's actually being delivered and recognized in a given country context. Next slide. So let's quickly look at 4 other real-world examples. First one here is a woman got IFA from a government clinic and took it for 270 days. She would likely be covered. 2, a woman bought IFA from a pharmacy and took it for 270 days. Maybe she would be covered, but it's a private product. So it depends on how we define the intervention, and does it matter where she received it? Does the composition meet the requirements that are set in the policy? 3, a woman took IFA for 90 days and MMS for 180 days. Well, this is a mixed regimen, so is she covered? And then the last one, 4, a woman received a high-dose iron as treatment for anemia. So this isn't, this is preventative, not preventative. Would she be covered? These are really just here to show the complexity, again, of defining what covered means. And it's not just about what a woman took, but where she got it, why she's receiving it, and what we're trying to measure here. Next slide. So here are just some example questions that you would need to think through while considering coverage. So where did the woman receive the supplement? What is the composition? When did she start and stop taking the supplement? How many did she take each day? And did she take it daily? Next slide. Just to wrap up here, a few measurement challenges to consider. MMS doesn't have a distinct visual marker like the red, like IFA tablet. Many MMS products exist, each with different nutrient profiles, and women may not be able to differentiate between products. And Unimap is still early in the rollout, so the recognition of it is likely is low. The key message is that you need to deeply understand the product, the target population, and delivery methods to be able to make a decision of the intervention. And defining the intervention is just the first step, and one that needs to align with both policy intent and data collection realities. Next slide, and over to my colleague, Hannah.
Hi, good morning, good afternoon, everyone. So I'll continue with the next step 2, which is understanding context and how respondents conceptualize and recognize the intervention. Next slide, please. So this is just an iteration of the indicator development process that was mentioned earlier. Next slide, please. So these are the focus areas for the next couple of slides, where we will talk about identifying key elements of the intervention and what consultative processes that were followed. Particularly, I will be focusing my presentation around our experience in Ethiopia. Next slide, please. So the first thing that we need to consider is how do women conceptualize and recognize iron-containing supplements? You heard from previous presenters that there are multiple forms, IFAs, MMS, and other supplement types, which are confusing for the woman. Next slide, please. So when creating questions, key questions for an indicator, we need to understand primarily if the woman is understanding what we are asking. There should not be a disconnect on what the question is referring to and what the woman is understanding or considering when she's responding to the questions we are asking. The image you see to your right are examples, real-life examples of the different forms or supplements women have been exposed to during their pregnancy. And you'd see that there are some listed as iron containing, but they are not. So we need to understand that we are talking about similar products when we are asking our questions. Next slide, please. When women are asked whether they receive or consume iron-containing supplements, particularly iron folic acid tablets, their responses hinges on whether they can correctly identify the supplements. But there are multiple factors that hinder this because these iron-containing supplements come in different forms, tablets, capsules, in different forms. They do not have consistent labeling. They may be dispensed in unmarked blisters, loose forms with no clear instructions or brandings. They may also be confused with other medications that women are exposed to during their pregnancy. In addition to the supplement characteristics, how women identify will also matter on her own literacy level, both health and her ability to read instructions. So without appropriate visual aids and verbal reinforcements, women may not understand and comprehend the questions we are asking around the supplements. Therefore, we need to consider these complexities when we are developing questions. Next slide, please. So why should we worry about women not recognizing IFAs? This is just a poll. If you do, yeah, I'll give you a few seconds for everyone to respond. Next. If we could see the results.
Would you like me to go to the next slide?
Yes, just to see how everyone responded. Yes. So this is really nice. As correctly mentioned, both are correct. We may have false negative. Women may have received or consumed the IFAs, but report no because they did not recognize it as such. The second one is we may have also false positive. She may report taking IFAs when it was actually a different supplement she was taking. So this will have an implication in our measurements. Therefore, we really need to understand whether our respondents are recognizing the same things or understanding the same things that we are asking. Next slide, please. So in order to ensure that we are asking the right question and using the right terminology, we need to understand what are the locally recognized names. What are the health professionals, the pharmacists using when they are prescribing these medications or these supplements? What are the women using to refer to these supplements? If, for example, they are using the term red pill, unless our survey tool or question have some indication of that red pill concept, it will be difficult for them to respond correctly. Therefore, understanding the terms and visual prompts used to differentiate the supplements is important to improve recognition by the consumers, and that will also enhance our data accuracy. Next slide, please. So now I will just give you an example of what we did in Ethiopia. As mentioned earlier, this study was done in two settings, Bangladesh and Ethiopia. But for the coming slides, I will be focusing on what was done in Ethiopia. So we started off with a comprehensive landscaping of, and in that process, we had discussions with different stakeholders, the women, which were currently pregnant and recently delivered women, and also health professionals, which were directly related with prescribing this medication and providing them. As mentioned earlier, we had also identified that different facilities would have, individuals at different facilities would have different exposure. So we had also diversified the stakeholders by their social strata, as well as the facilities they were working in and also receiving their ANCs. Following that, we had a series of open-ended questions about the product, asking the women and other stakeholders what kind of product they were exposed to during pregnancy and which products do they identify. Next slide, please. So these are just the set of pre-designed questions. We had interviews with mothers and other stakeholders. So we could go to the next slide. So for the next slide, please. For the discussion, what we used is a methodology. It's a qualitative methodology where we explored how groups of people think, what they think is most important, how they defined a particular nutrition and health related domain by asking them to list all the items that comes to mind. For this particular instance, we asked a question: when women in your community are pregnant, what products are they exposed to at health center, pharmacy, and market? So they came up with a list of responses. I will show you in the next slide the responses. But one of the benefits of this methodology was it was quite straightforward, and it gave us a swift insight of the community practice and perceptions. It also gave us an understanding of the local language and priorities within the setting. Next slide, please. So in terms of the sampling and how our sample was selected, I mentioned it earlier, so I will skip that part. But when we look at the results or the list that was provided, these are actual examples from the list generated from the individuals. You could see that some of them just listed one item, others more. And also there are variations in the terms in the terms that was used to describe the product they were exposed to. Once we had this comprehensive list, what we did is we analyzed for salience, that is considering what was most frequently mentioned, in what was the order it was mentioned in. Items listed earlier are often more salient. And we also saw from this what the shared patterns were across the different participants. Next slide, please. So the three salient terms for our context that was identified were iron, prenatal, and vitamin, as you can see here. Next slide, please. Following that, we also had additional questions trying to understand how the appearances, frequencies, and purposes for the different products is, and the variation between the different groups in explaining those differences. Just to summarize some of the key findings we found from this exercise was women in the highest socioeconomic strata received both IFAs and also multiple forms of micronutrients, different brands. We also saw that women's exposure to iron-containing supplements varied by health facility they were visiting. Those visiting in health government health facilities were exposed to IFAs, the generic brand provided free of charge by the government, while others going to the NGO and private clinics were exposed to a variety of products. Next slide, please. And from the insight we got from this exercise, one important thing that we saw that was products that was listed early and often listed are the most popular ones. And this pattern hints to the values and cultural context, and understanding the salient terms and those terms that resonated most with the woman or the consumer helped us design better survey questions. We'll see more details on the next presentation, but I'll end here.
All right. So hi, everyone. Thank you for sticking with us throughout the webinar. My name is Emily Myers, and I'm going to give us a short and sweet introduction to using cognitive interviewing, which is a strategy you can use to design and refine your survey items. So next slide, please. So really the challenge is, when you're face-to-face with your respondent, you really want to know if your respondent is understanding what you're asking them. So, we just want to make sure that we've refined our survey questions and that they're well comprehended before we're actually, running that full household survey. Next slide. So we're going to start off with a poll. It's a little bit different from the other ones in that it's an opinion question. So if you could open up the poll, the question is, and don't overthink it, but just on a scale of 1 to 10, how much do you like eggs? So I'll give everybody a few seconds to think about how much they like eggs on a scale of 1 to 10 and rate. All right, let's go to results. Oh, there we go. Okay, so we have a kind of wide range of answers. So I know I said that this was an opinion question. It was a little bit different from the other polls we've had so far. But I can confidently say that all of your answers are wrong. And you might be thinking, well, it's an opinion question, it's personal preference. There is no right or wrong answer. But cognitive interviewing is how we know. So for instance, did number 1 on the scale mean that eggs are your number 1 favorite food? Or did 10 mean like 10 out of 10, you really like eggs? Or you might have been thinking like, well, what form are the eggs? Because some people really don't like scrambled eggs, but they really like chocolate cake, and eggs are an ingredient in chocolate cake. Or you might be vegan or allergic and be like, this doesn't apply to me because I just don't eat this food, period. So the point of this silly question is to point out all the different ways in which a seemingly simple question or a prospective survey item can go wrong, which is why we need cognitive interviewing. So next slide, please. So quickly, cognitive interviewing is a qualitative method, and the goal of using this method is to assess participants' understanding of different survey items. But so ultimately, you can conduct what are called cognitive interviews to improve your content validity, identify any discrepancies between, how questions are asked and interpreted, because, what we intend as a researcher might not be what a study participant like hears or understands, and we want to identify those discrepancies, which can help us identify potential sources of error. And then finally, in addition to improving the content validity, it also is a strategy that can help us maintain content validity across different subgroups, whether that's, educated and uneducated, or men and women, or women who are mothers or women who are not, whatever your subgroups within your population are, you can use cognitive interviewing to kind of explore how they might interpret the same question differently. Next slide, please. So earlier on the previous slide, I had mentioned these discrepancies that can occur kind of at any point of asking and answering a question. But so there's 4 cognitive stages, or 4 main cognitive stages, and these discrepancies can occur at like any of these 4 points. So one of the first is the comprehension. So it's just, how a question that you're asking is interpreted. And comprehension error then would be your study participant not understanding the question as you intended. So sometimes you're using words that are unfamiliar, or there's an ambiguous concept, or, sometimes your question is just like too long and too complex. It has too many words for somebody to follow. Next is retrieval, which is what happens when, oh, I'm sorry, not the next slide, just the next row. Thank you. So retrieval is, recalling the information that's being asked about. So the cognitive error then is, asking, or is someone not remembering? So for instance, if I were to ask like what you had for breakfast on December 8th, 2016, you probably don't know. So these retrieval errors are caused by this kind of recall difficulty, and just kind of the assumption that the respondent has the information that you're asking for. The next type of error would be judgment, which is when your respondent is evaluating and estimating their response. And it's the kind of error that produces, social desirability bias, for instance. If someone feels judged by a question, they might not want to give you the answer. So typically they happen when you're asking sensitive questions, or, about a taboo, or whatnot, and the respondent isn't sure if they want to be truthful or how truthful they should be. And then finally, the last cognitive stage is response. And that's really just, are respondents able to provide the information that you're asking about in the format requested? So sometimes you can't respond in the format. So sometimes you just have incomplete response options, or your survey is set up to allow for a single response option, but really they need to have like a multiple response option opportunity for respondents, for survey respondents, to give you like a full overview of what the actual truth is, their answer is. So next slide. So there's a few different ways to go about actually doing a cognitive interview to discover cognitive errors. For our study, we use scripted probes. So you can kind of see in the table, we have the survey item, during your last pregnancy, were you given or did you buy a vitamin tablet or syrup? And so we actually first start with like a retrieval question where we're asking, can you explain to me the time period of the question we were talking about? So they might say, oh, the last time I was pregnant, or they might say, if they were recently delivered, they might say, oh, in the 9 months before my child was born, something to indicate they're actually thinking about the last pregnancy. And that part of the question didn't just, fly over their heads. A comprehension probe might be reiterating a key phrase or key topic. So in this case, vitamins. So, you would ask a question like, I asked about vitamins in my question. Can you explain to me what vitamin means in your own words? And then you can hear whether or not your respondents understand the key topic. And then also judgment, particularly if you're working with like a low resource population. They might not want to share that they weren't able to get vitamins or, vitamin or syrups, what have you, because, they might know it's good to do for their baby. They might know that they couldn't afford it, but they want to give the right answer, which is, being a good parent and, taking those vitamins and whatnot. So we might ask a judgment question, just saying, oh, was this question easy or difficult for you to answer? And you can get a sense of, whether or not judgment errors are happening depending on what respondents reveal. Next slide. And then finally, I couldn't think of a response like scripted probe to look at response errors for the last question. So we have a new survey item, just, during your last pregnancy, how many weeks or months pregnant were you when you first started taking a vitamin tablet or syrup? And so, people would give their response, and then you would, probe by saying, oh, you said you first started taking vitamins when you were, 12 weeks pregnant. How did you come up with this answer of 12 weeks or months? It'll help you verify if the response they gave you seems accurate, or if they really know what they're talking about. And some people, might say 12 weeks, but it's easier to think in months because there's fewer months, right, of a pregnancy than if you were to think about it in terms of weeks. So it just kind of depends on, who your population is, what all you can do as far as response errors go. Okay, next slide. I know we're running out of time. So we just wanted to give you a quick overview of some sample results from Ethiopia for the survey item. During your last pregnancy, were you given or did you buy any vitamin tablets or syrup? So we checked for comprehension for, whether given or buy was understood. Both of those were well understood. We also tested prenatal or folic acid, and neither of those were well understood. And finally, we tested vitamin or iron and how those were comprehended. Vitamin had mixed comprehension, but we found that iron was very well understood. So next slide. So given our results, we decided to run like a second round of cognitive tests. And so we knew from round one that given or buy was well understood. So we didn't probe that anymore. Given that both prenatal and folic acid were concepts that were not well understood, we tried a new one where we just said, iron or iron folic acid, particularly because we knew iron was well understood. And so kind of framing the prenatal folic acid in this way definitely cleared things up, and it was much better understood, in the additional tests. And then finally, for testing vitamin and iron, another time, we found iron with many vitamins was well understood. And we had also tried a local word, the kinin, which is like the word for pill, a pill for anemia, just based on what we knew about what like local implementers and local, shops and pharmacies would have. And we were thinking, okay, maybe that word will make more sense. It's a more local word, but it was not well understood. Next slide. Maybe there's some delay for the next slide. There we go. Okay. But so kind of reviewing all of the results about what was well understood, what was not, what was well understood, the second time, we really found that distinguishing between an IFA and MMS is really challenging for study participants. And we found that visual aids and using like the same phrasing as local health facilities, later on really improved comprehension. So it's kind of how I'm just trying to walk you through like, here's what we would test, here's what we found, here's how you might try again to improve. But ultimately, when you consider all of the results together, you can learn about, what the kinds of errors or problems you might have in a survey item are and continue to adjust for them and refine your survey items. So next slide. I think that was the last one actually. Thank you so much. And we'll move into our Q&A. I know we're at about time, but hopefully you can stay on a bit later to chat with us.
Great. Well, thank you again to all of our presenters. I hope that you feel like you've come out with learning some new steps and tools. I think that just due to timing, I'll maybe just pose one question to all of the presenters, and then we'll say thank you and goodbye. So in our presentations, we really focused on maternal supplementation and that specific intervention. But I'm really curious, and I think it would be useful if you could talk a little bit about other interventions and how we might apply these same approaches to those other interventions. So maybe if we want to start with Sunny, and then we can kind of go around, and anybody that feels like they have an example from another intervention to expand on.
Actually, I'm going to let each of the presenters of the steps go first, and then maybe I can just comment overall.
Great. Just starting with step one and thinking through how we can apply the concept to another nutrition intervention. So I'll think through two different examples of large-scale food fortification and nutrition-sensitive social protection programs. For these, the first step would be in designing effective household survey indicators is to clarify whether the program or intervention meets the criteria of large-scale food fortification and nutrition-sensitive social protections. And then once that is established, you can clearly define what the intervention is in a way that reflects the in-country program realities. So including how the intervention is delivered, as well as the respondent's ability to report on the intervention. So that's thinking through the terminology, packaging, and different recall patterns. For both of these examples, indicator design require clarity on what we're trying to measure and the delivery mechanism. And to do this well, you would need to bring in expert consultation as well as formative research and policy landscaping. These are all really critical to be able to inform whether the survey questions are appropriate, feasible, and like meaningful in the way that you're trying to measure within the local context.
Great. Thanks, Alina. Hannah or Emily, did you want to expand on that?
No, I just see another question came in specific about cognitive interviewing, so I was going to hold my comments actually.
I just wanted to add that most of the methodologies and steps followed can be used in multiple other forms. Most of the steps, having this stepwise approach simplifies these complex processes. Some of our questions are quite complex. So by breaking it down, simplifies the complexity, it improves the accuracy, and also enhance the learning process. So I think it can be applicable in many other similar surveys.
Right. Yeah, I think like my comments more or less reflect that too, just thinking solely about the cognitive interviewing. And like my primary background is actually in gender research. So we've done a number of studies looking at doing the cognitive interviewing to try to measure concepts like empowerment and agency, and things that literally aren't as like material, as tangible as like a tablet or a syrup someone might take. So I definitely think like it's the kind of qualitative strategy you can use regardless of what your ultimate quantitative survey instruments might be. But I also see, a question from the Q&A, if someone's not giving the correct responses to our questions, how do we address this? I would push a little bit of a reframe. And I think this is part of what makes like step 3, the cognitive interviewing, a little more distinct from the others that Alina and Hannah presented. But I would push a reframe and say, it's not that the respondent is giving the wrong answers, you're asking the wrong question and your question isn't clear. And it's your job as the researcher to figure out how to reword your questions to be interpreted the way you're intending them to interpret. And of course, like things can be messy and challenging, like concepts are complex and can be abstract and actually measuring them can be hard. But I think it's better to do cognitive interviewing and, potentially what the limitations of, whatever final household or larger scale survey you do are when measuring something really complex than to just skip the cognitive interviewing because you're like, oh, well, it's not going to be a perfect tool anyway because the topic's so complex. But I also see another question. Sorry, Shelley, I don't know if I'm doing much, but I know we're over time.
That's great. Yeah. That's great. I really appreciate you expanding on that. I think maybe we'll give Sunny the last word here, and she can either add and expand on what you all said, or Sunny, there is also this validity question that came up. So I'll let you choose, and then we'll close it out.
Sure. And thanks to all the presenters. I think the stepwise different examples of the methodologies applied and the steps that were taken to the approach to rethink and possibly design and develop measures and indicators are really applicable across all different types of interventions, actually. And I just want to say that, these methods were applied to build the evidence for strengthening and improving the measures, even those that are longstanding. I think Lena started off with the IFA supplementation receipt question and whether or not those were providing accurate estimates and the challenge that was posed there. So these methods can be applied to build evidence across other intervention coverage measures and potential solutions, because we need to have not only show that there are errors, but the potential solutions, alternative solutions. But as one of the commenters also mentioned, that it's really important to make, in order for these measures to be standardized across different sites and over time, they do require consensus and among experts and stakeholders, and that we are not recommending that everyone adapt every question in their homes, their surveys to the local context, and depending on their context of where they are and working and studying or researching, and that these methods are there to build the evidence, provide potential solutions, and that we do need to come back and bring this to the wider community context to discuss about and consensus about standard indicators. But again, I'll just stop there and say that we hope that these applications were useful to you all, and we look forward to sharing out our findings and our different methods.
Well, thank you, Sunny. I can't say it any better. So just a thank you again to all of our panelists and for the community for joining today. And Cecilia, back over to you if there's anything else that you wanted to add.
No, thank you, everyone. Thanks for all participants for staying a few minutes over. You can go to our LinkedIn group for the slides later, and also to our YouTube channel for the recording. But thank you, everyone. Have a good rest of the day.
Thank you.
Thank you.
Thanks, everyone.
We appreciate your attendance and questions.